Hello, it's Dr. Evie Kemp here again with lesson 5, which is to do with stress and burnout among physicians. So these are the learning objectives for lesson 5. We're going to be familiar with the unique stressors associated with being a physician, along with the possible ways of coping with stress, and describe the role of the provider in facilitating the emotional well-being of patients. So, well, let's start. Who wants to be a good doctor? Well, I'm sure, of course, all of you want to be a good doctor, but gosh, it takes a lot of attributes to be a good doctor, doesn't it? This is actually a systematic review looking at what the most important attributes are for doctors. And they asked doctors and they asked patients what the important attributes were. And these were some of the things they came up with. So having interpersonal qualities, good communicators, medical competence, understanding medical ethics, being good managers, being good at teaching, research, continuous education, and so on. There's an awful lot there, isn't there, to be a good doctor. Interestingly, the top of the list for the doctors was actually medical competence, and top of the list for the patients was good communication. So anyway, those are the attributes of a good doctor. That's what we're all aiming for over our lifetime of being a doctor. But there are many hurdles to get there, and we have to start jumping these hurdles really when we're pretty young. When we've decided we want to go to medical school, there are exams that we need to do before we get there, and interviews and things that we have to do to show that we're the right sort of person. And then when you're in medical school, there's the next exam and the next course. And then when you've qualified, you've got postgraduate examinations, and it goes on and on and on. So we learn very, very early to delay self-gratification, to delay looking after ourselves. That's a really important thing just to bear in mind. So let's just talk a bit now about doctors' health and well-being. So we'd start just with physical health. And as an occupational health consultant, I looked after a lot of doctors in my time as patients. And from a physical health perspective, we have the same health problems as anybody else, but we have some interesting and important work-related problems that we need to think about as well. So lots of people with hand dermatitis, and sadly I looked after surgeons with hand dermatitis, where the dermatitis really affected their ability to work. So lots of doctors who, after moving patients, had manual handling injuries and hurt their backs. We need to know how to manual handle patients well. I saw lots of doctors with wrist problems, what we call work-related upper limb disorders, from saying doing ultrasound over and over again. I saw pathologists who looked down microscopes with neck problems, and so on. So physical health problems, there's lots to do and lots to help us with those things. But today I really want to concentrate on mental health. Now, medicine is an amazing and wonderful profession. However, whether we like it or not, we have a significant increase in anxiety and depression compared to the rest of the population. And we also have significant issues with drug and alcohol abuse. And sadly, one British Medical Association report from quite a few years ago now suggested that 1 in 15 of us may have a drug and or alcohol problem. And the group that we see most problems of drug abuse in are actually anaesthetists. Majority of them are male and under 40, and they're most likely to abuse narcotics and IV drugs that they've been using in theatre anyway. And sadly, fentanyl is the drug of choice. And if that wasn't enough to depress you, very sadly, as a medical profession, we have an increased relative risk of suicide compared to other professionals, higher in women than men, and higher in some professions, particularly family doctors, psychiatrists, and anaesthetists. And incredibly, in America, the statistic is that between 300 and 400 doctors a year commit suicide. I mean, that is a huge number. That's a terrible, terrible disaster. It's of epidemic proportions. And we're very good at completing suicide because we know what to do and we have access and knowledge about drugs. The only slight piece of good news, it's not good news, but is with the one group that's even worse than that is actually the veterinary surgeons. And that's because they have access to animal drugs and guns to kill large animals, so they have access to things to actually kill themselves maybe more easily, but also not good at all. And it's a very interesting study that was done looking at suicidal ideation in American surgeons. And it was done by the American College of Surgeons, and they sent a cross-sectional anonymous survey to everybody who was in the American College of Surgeons. That's 25,000 people. That was done in 2010, this survey. And they had not a bad response, a nearly 32% response rate. And in fact, 501 surgeons, that was 6.3% of everybody that responded, had actually experienced suicidal ideation in the last 12 months. And that was significantly higher than suicidal ideation in the general population. And that suicidal ideation was strongly related to depression and burnout. But the figure that most worried me in this study was this figure, that only 26% of those surgeons had felt that they were able to seek help. So what are the barriers for doctors seeking help? Because we're not very good at it, are we? So first of all, there's the stigma of mental illness. Now, 1 in 4 of us is going to have a psychological illness at some point in our lives, and we need to treat this exactly the same as any physical illness. And we need to get over this as a profession, and we need to, if we can't get over this issue of stigma as a profession, how can we properly treat the patients in our care? So it's a huge piece of work that we all have to do. Workload and time off. We're ever so busy, aren't we? We haven't got time to get sick. Goodness me, no. Access to confidential services, that's extremely important, that there are special, nearly most doctors will prefer to go to services that are specially set up for doctors, but what's most important is that those are confidential services and you're not going to be sitting next to one of your patients in the outpatient department. People worry a lot about future job prospects. I can tell you about the UK, which is certainly in the UK with the disability discrimination laws there. So long as somebody is well and they've recovered, we would always get them back to work, sometimes with special adjustments in place as well. We have a medical culture of self-reliance and coping. It doesn't happen to us. We're going to manage fine. And we also have great fear of regulatory involvement. So again, I can tell you about the UK. We are regulated by the General Medical Council in the UK. And there's great clarity now that so long as a doctor is getting the right help and treatment and doing what they're told by another doctor, the GMC does not need to know about it. So it's great that we've got that clarity now in the UK. But still, we don't, we deny that these things are ever going to happen to us. So this is a quote that we're ever going to get sick. This is a quote from a middle-aged oncologist with metastatic cancer. And this is what he said. He said, "We doctors wear magic white coats. We destroy disease all the time. How could it ever attack us?" And this quote is taken from a book called When Doctors Become Patients, written by a psychiatrist called Robert Klitzman, who very sadly lost his sister in 9/11, became depressed, couldn't believe that as a psychiatrist, he himself had become depressed. And as part of his rehabilitation, started looking and talking to doctors who were also patients, and then wrote this excellent book. And as doctors, we don't behave like normal patients when we get ill. Many of us don't have a family doctor, though of course we should. If we have a family doctor, we don't necessarily use our family doctor because we're so busy. We all self-diagnose. So at the end of a very busy clinic day, you've got this terrible headache, and it's actually pretty clear that the reason why you've got a headache is you haven't drunk enough and you haven't had lunch, but actually you immediately think to sort of the worst, rarest cause of headache that you can come up with. And we self-prescribe even though we shouldn't. Again, in the UK, it's very clear now, the GMC tells us that we absolutely should not self-prescribe. We should not prescribe for our families or friends unless it's an absolute emergency. And if we do, we need to tell their normal physician. So it's very clear in the UK. I know it's less clear in some other countries. And we do something called corridor consultations. So we're ever so busy. So I woke up this morning with a horrible rash all over, and I'd love to go, I don't know what's going on. I'd love to go and see my GP, my family doctor. I haven't got time. Walking down a corridor, I see a lovely friend of mine who's a dermatologist. And I say, "Oh, wait a minute, listen, just have a quick look. What's going on here with my arm? What do you think?" And she says, "Yes, it could be this, it could be that. Why don't you try and take this?" And I have A consultation in a corridor. Now, corridor consultations are not very good. You don't take a proper history, you're not examined properly. That's not the way to get good treatment, but many of us do that. So next time you're tempted to have a corridor consultation, maybe stop yourself and see if you can have a proper consultation instead. And there's lots of management problems with doctors as well. So often it's very unclear in hospitals and out of hospitals, who is the manager of the doctor? If they are sick, who's going to write them a sick note or a fit note or a doctor's note? Who's monitoring their sickness absence? And if they're going to be referred to someone like me in occupational health, are they referred in the normal way, in an appropriate way? And many doctors manage other doctors, and they often forget that they're not doctors when they're managing, because they try and manage, not treat. So for example, when I was working in the hospital, as an occupational health physician, I would often get a senior doctor phone me up and say, Evie, listen, I've got a junior doctor that I'm worried about. They have told me that they're depressed. They're having a lot of side effects from their medication. They were on X medication, and I think maybe I've suggested they start Y medication. I say, hey, wait a minute. You are not their treating doctor. You are their manager. You need to step back from that treatment. Yes, please refer them to see me, but then continue to manage them. We're not very good at that, are we? And we need to think about the impact of health on work. Now, I wonder if you've heard of something called presenteeism. Well, presenteeism is the opposite of absenteeism, and it's being in work when you're not well enough to be there. And doctors are very good at this. And if you're in work and you're actually ill and you're not well enough to be there, it can really compromise patient care. You can expose colleagues and patients to harm. And if you yourself are recovering from something like surgery, it can slow down your recovery. And we know that health can have a significant effect on performance. Now, in the UK, there's an association called the National Clinical Assessment Service, where doctors with performance problems are referred after they've had a local assessment. If they're still worries, they haven't got to the bottom of the problem, they're referred to the National Clinical Assessment Service. And the first thing that happens is they have a full occupational health assessment. And 25% of cases are found to have a significant health problem, which is affecting their performance. Things like early dementia or depression or taking medication that's affecting performance. There's another interesting American study which was looking at depressed junior doctors, and it showed that they had a 6-fold increase in medication errors compared to their non-depressed colleagues. So lots of impact on health on work. So next time you're poorly and you're really not feeling up to it, have a good think about whether you should be in work or whether you should be maybe off home for a day. But what about the flip side of that, which is the impact of work on health? And this is a very detailed slide. It's almost a lecture in itself. But here, there's 6 areas of workplace design that, if not properly controlled, can lead to stress. Things like demands, control, what's coming through the door, and so on. I'm going to talk about this a bit more in a minute. That affects all employees. And of course, all of that's affected by the culture of the organization as well. That can lead to individual symptoms of stress, things that we've already been talking about on this course, palpitations, back pain, raised blood pressure, so on. And in the long run, that can lead to physical and psychological individual symptoms. But it also affects the organization. And it affects the organization because this leads to increased sickness absence, it increased staff turnover, reduced staff performance, increased staff mistakes. And that actually costs the organization a lot of money with increased litigation, increased accidents, costs money to bring new staff in if there's high staff turnover. So it's really important that the managers of an organization understand that, as well as a duty, an ethical and moral duty of care to look after their staff, it's actually helpful for the organization, and it actually can reduce costs and overheads in the organization. So it's really important that we look at the impact of work on health. And as I said, in the UK, there's something called a workplace stress risk assessment, and we use something called the Health and Safety Executive Management Standards. And the management standards are actually 6 areas, as I said, of workplace design that, if not properly controlled, to lead to stress. So they are demands. What is coming through the door? How many patients are coming through the door? Very hard to stop demands in healthcare because the patients keep coming. The next one is control, but actually how much control have you got about how you manage your workday? Can you manage to organise that you have a break so you actually have something to eat at lunchtime? Have you got enough control that you can organise your clinic? So if you know a really complex patient is coming in, you can block off more time. Can really help to reduce stress if we have some control. Support is another hugely important area. Have you got the support of your colleagues and of your seniors, of your managers? Relationships, very in the workplace, also extremely important. And we know there are often dysfunctional groups of doctors, sadly, in organisations. So those relationships, working on relationships, making sure bullying and so on doesn't happen is vital. The fifth area is role. Have we got real clarity in what we're being asked to do in our job role? Because that really helps. And the last one is change. How is change managed in your organisation? And change will happen all the time, everywhere. And of course, it happens in healthcare. But how is it managed? Are people told about the change up front? Are they helped to come along with management along the way? And you can do, when you do a stress risk assessment, you sit down with your team, you look at all these areas together, and you try and come up with ideas together to try and reduce the risks. And it's a bit like an audit circle. You come up with ideas, you come up with who's going to do it, and you keep reviewing it and going around in a circle. But chronic stress ends up in burnout. And burnout is actually a work-related syndrome of chronic overstress that occurs in mainly, but not only, the caring professions. So we're talking about doctors, nurses, teachers, social workers, and so on. It was described by Christina Maslach in 1997, and it's got three main areas. There's emotional exhaustion, that you've just got no spare emotional energy left for your patients. Depersonalization, you can't even see your patient as a person anymore. It's like the gallbladder in bed 5, not Mrs. Smith with cholecystitis or whatever. And then there's a real decreased sense of personal accomplishment as well. And you get to a point of physical, psychological, and cognitive exhaustion and total disengagement. And sadly, burnout rates, not just in UK doctors, but around the world, are running high. This was one systematic review of 14 studies over 20 years, suggesting, high levels of these three burnout areas in doctors in the UK, and particularly high emotional exhaustion in family doctors. The amazing thing is we're terribly good at hiding this from our patients. Patients don't know we've got problems till, that's the last thing that goes. We're not going to let our patients, we want to give our patients, despite all of this, good care if we possibly can. And this is another interesting study looking at burnout and career satisfaction in American surgeons again. And these surgeons had all been on average, they'd been in practice for 18 years. They were on average working a 60-hour week, and they were on call 2 nights per week. And they had a 40% of them were burnt out, and 30% of them were suffering from depression. And it was very interesting to see which factors were particularly associated with burnout. Younger age surgeons with young children, I guess that's probably to do with sort of juggling home and work life. Certain areas of specialisation, well, trauma, maybe that's not surprising, but also urology, vascular and general surgery. The number of nights that you did on call per week, well, that makes sense, doesn't it? Just from exhaustion, and the number of hours per week you work. And also, this was America, so compensation based only on billing. And certainly 36% of them said, only 36% of them said they had enough time for their personal and family life. So it's this terribly difficult problem of juggling everything that you need to do. And interestingly, that this study showed that burnout was the single greatest predictor of satisfaction with career and specialty. So let's think about stressors in doctors. We've just been talking about that tightrope between work and home, haven't we? And let's look at issues impacting the health and well-being of doctors. So in blue purple here, these are the things that I normally talk about, and I'm going to talk about in a minute, but we really can't not talk about COVID-19 at the moment as well. is a huge additional stressor to healthcare workers all around the world. And pandemic related stress as well. This was one study from 2020 where they actually did 8 listening sessions with different groups of healthcare workers, and these were the most important stressors for the healthcare workers at that point. Firstly, access to good enough personal protective equipment, masks, gowns, so on. Worrying about taking COVID-19 infection home to the family, having rapid access to testing, who was going to look after their families if they got sick, who was going to look after their children while they were at work, who was going to support basic family needs due to long hours, for example, buying food. And again, in the UK, the supermarkets actually put aside food for healthcare workers in a certain part of the supermarket to make sure that when they came maybe after work in the evening, there would still be food for them. And of course, also being able to provide competent medical care if they were deployed to a new area. A lot of doctors and other healthcare workers were deployed to areas that they had not previously worked in, and found that very stressful. And the other thing is that the COVID information is just being updated all the time, and it's just managing to keep up with that information and being having the right communication to help people keep up. And then there's this interesting area of moral injury. Moral injury is when you're being asked to do something that is morally immensely difficult for you. So for example, if you've got 1 ventilator and 2 patients and you have to choose which one you ventilate, that can lead to moral injury, and moral injury is associated with increased incidence of post-traumatic stress disorder, depression, anxiety, and so on. And here's another very interesting paper that was published in November 2020 from Med Archive Online. And this is actually looking at the mental health of staff working in intensive care during COVID-19. And this actually looked at 709 ITU staff. About half of them were doctors and half of them were nurses. And nearly half of them had symptoms consistent with a probable diagnosis of either depression, PTSD, anxiety, drinking, and suicidal ideation. And 39.5% had symptoms consistent with a probable diagnosis of PTSD. I guess that's probably the most worrying statistic there. So let's go back to the issues impacting on health and well-being of doctors before the pandemic. And there are many. So all those years studying, the challenges of work, things like, you can injure yourself at work or have a needle stick injury, or there could be bullying at work, or very difficult patients, or just managing all the things that you need to do. You've got to fit in everything in your home life as well, haven't you? You've got to have time to have relationships with people and to nurture those relationships. You've got to be able to manage your finances, and many medical students sort of start work now with huge debts. There's this medical culture of we don't get sick, we carry on regardless, it's not going to happen to us. There's all those biological factors, things like no time to eat, not sleeping well enough, working long hours, being on call, and so on. And there's also the medical personality. And many doctors like me, I'm happy to put my hand up and say this, are self-critical perfectionists. I'm a self-critical perfectionist. Many of us are, and it may not necessarily be a good thing. I'm going to show you a bit more about that in a minute. So we're going to just mention something called a double bind. So a double bind is a dilemma in communication in which an individual or a group receives 2 or more conflicting messages, with one message negating the other. So here's an example of a double bind. To be a good doctor, one needs to be able to relate to patients and be capable of empathy and humanity. I'm sure we'd all agree with that. And I want you to look very carefully at this cartoon. And the doctor says, I think you'll find I'm one of the most empathetic doctors around. So I'll just let you look at that cartoon and see why. Yet, to survive emotionally, one needs to be detached from patients' pain and suffering. So that's the double bind. How do you do those 2 things at the same time? And there is, without doubt, an emotional cost of caring. This picture was actually taken by a paramedic of his colleague with consent, and his colleague was an ER doctor in Southern California, taken in 2015, and he was just completely gutted and grieving the loss of a 19-year-old patient that they'd both been working on, and sadly, they lost him. He passed away. And this picture went viral, and there's a lot of response on social media. And this was one of the responses. It was from an ER doctor called Smee, and he wrote the following: "When it comes to our work, nothing is harder, and I mean nothing, than telling a loved one that their family member is dead. We can only do so much, and we can only hope to do our best. But it's that moment when you stop resuscitation and you look around, you look down at your shoes to make sure there's no blood on them before talking with family. You put your coat back on and you take a deep breath, because you know that you have to tell a family that literally the worst thing imaginable has happened. And it's in that moment that I feel, and I feel like the guy in this picture." And here's another double bind. Doctors need to be obsessional and self-critical to avoid mishaps. Yet, higher levels of self-criticism are associated with high rates of depression. So if you're a patient, it's great that you've got a obsessional and self-critical doctor, because they're going to double check and make sure and double check again. But if you're the doctor and you keep double checking and you keep being critical, you're beating yourself up, and that's associated with higher rates of depression. So what about prevention? Can we prevent? What can we do to prevent? Well, I think we can do work on prevention, but we need to look at a 3-level model of prevention. So that's primary, secondary, and tertiary prevention. And this is work that comes out of this excellent paper from the Society of Occupational Medicine called "What Could Make a Difference to the Mental Health of UK Doctors, a review of the research evidence." So primary is trying to avoid or reduce risk in the workplace. So that's doing that workplace risk assessment. That's the management role, to try and reduce risk of stress wherever possible for healthcare workers. Secondary prevention is giving workers, doctors, tools to help them manage their work environment. And tertiary prevention is making sure that there's early and confidential rehabilitation and treatment for mental health problems. And unfortunately, too many organisations think that if they give workers secondary prevention, that's all they need to do. So here you go away, have a mindfulness workshop. We'll organise a mindfulness workshop for you, and then everything's going to be fine. Well, it isn't that simple. All the research says we have to do primary and secondary together, and ideally all 3 of these together. So what about some stress busting tips? I believe, and I do a lot of training for doctors and medical students, that everybody has to have their own toolbox. Everybody's got to work out what works best for them and have a range of options and ideas in their toolbox for managing stress. And ideally, we're going to teach that at medical school and keep teaching it all the way through our career in medicine. And there's a great report called The Basics by Dr. Mark Kaufman, who's the director of the Ontario Physicians' Health Programme. And he divides the things we need to be thinking about into BAS, ICS. So that's B is body, biology. A is affect, that's our emotional states, our personal attitudes, our self-awareness. S is social, so that's looking after our friends, our lovers, our family. I is intellect, that's the power of the mind to manage stress and challenge those negative thoughts. C is the importance of building community, and S is the importance of spirituality. So let's look at this in a bit more detail. He also talks a lot about homeostasis versus allostasis. I mean, we've talked about this already in several different ways, but you know, in an ideal world, if our bodies are in homeostasis, we can keep and maintain our internal physiological environment within healthy limits. So that means we drink when we're thirsty, we eat when we're hungry, we sleep when we're tired. But unfortunately, if we can't do those things, and often as doctors we can't do those things, you get chronic wear and tear on our bodies. It's called allostatic load. And when we are in that state, we are at risk of stress and stress-related illness. And, you know, doctors think it's not going to happen to them. Well, it's going to happen to us just as much and even more than other people. So let's have a little think. Self-care, sleep. Well, we all know the importance of sleep. We all know the importance of having a bedroom that's set up for sleep. The other thing that I do with our junior doctors is I actually teach them how to do night shifts. And this is hardly taught actually in medical school. This is a fantastic journal article in the Emergency Medicine Journal from 2020 with evidence-based countermeasures for night shift workers. I'm not going to go into this now, but do pull out that. If you're somebody who does night shifts, please pull out this paper or just have a look at this slide in more detail. Self-care, going to the toilet. We as healthcare workers are very bad at going to the toilet when we need to go to the toilet. Most healthcare workers will tell you that they've delayed going to the toilet because they're too busy. It's really important. We should look after our basic bodily needs. If you need to go to the toilet, go to the toilet. It's a bit like talking to toddlers, isn't it? So just remember, next time you need to go to the toilet, you go to the toilet. Food, really hard. Having good food available, being able to eat good food. You need good fuel in to keep going. Incredibly important. We know this. We did in one of the hospitals that I worked in previously, we did an experiment where we asked patients to, instead of bringing chocolates and biscuits to say thank you, we asked them to bring fruit to say thank you. And we had a huge fruit bowl on the ward. Just something to think about. You know, if you didn't have time for lunch, at least you weren't just reaching for the chocolates, but food, immensely important. Exercise. We know exercise is terribly important for every aspect of our health, physical and psychological. We know how hard it is to fit this into our busy lives. Here's a great quote. What fits your busy schedule better? Exercising 1 hour a day or being dead 24 hours a day? You know, even if it means you just take the stairs instead of taking the lift or the elevator, even if it means that you park 1 block further away from your clinic and walk, anything you can possibly do, try and do it. Just try and fit exercise into your normal working day. Beware that unhealthy behavior that you go home and have such a hard day, you pour that glass of wine and then you pour another one. Do please register with a family doctor or a GP, and do please use them. Cognitive errors, negative automatic thoughts. Well, I can't teach you how to challenge these now, but it's a terribly useful technique. When we are stressed, when we are down, we have faults in the way that we think that helps to maintain very negative thinking. So some examples of this are all or nothing thinking. If you're really stressed, you're really low, things are either black or they're very white. You can't see anything in between. There's a type of thinking called personalizing. You just assume that things are your fault. So for example, you see a friend of yours walking down the street on the other side of the road, you wave at them and they ignore you. You think, oh, good grief, what have I done wrong? And it turns out, you find out later, they didn't have their contact lenses in that morning. They didn't even see you. And the commonest one that we all do is called catastrophizing or jumping to conclusions. Something goes wrong. Let's say you make a mistake at work, and within literally 30 seconds in your mind, you've been told off by your boss, you've lost your job, you can't pay your mortgage, and you're all living in a cardboard box on the road. And we all do this. So if you can learn to catch these negative thoughts and to challenge them and say, these are just thoughts, these aren't reality, it's a terribly helpful and useful technique. Nurturing relationships. The doctors that I saw that really got into trouble were ones that were working so hard that they stopped nurturing the important relationships in their lives. And what I'm talking about is whoever that person or persons are for you. So whether it be your partner, whether it be your spouse, whether it be your parents, whether it be your children, whether it be your friends, you must make time to nurture those important relationships. It's also really important that you have time to do some sort of a hobby, whether it be something major like mountain climbing or just doing Sudoku. It doesn't matter what, but something other than medicine. Learning to say no, incredibly important. There's a great book called Iron Doc by a Canadian psychiatrist called Mamta Gautam, where she says there are 3 stages to saying no. Step 1 or stage 1 is opening your mouth. Stage 2 is saying no. Stage 3 is shutting your mouth again. It's a brilliant book. It's not as hard, but you know, we're very bad as a profession at saying no. Time management, well, there's lots of things we can all do to improve time management. One of the ones I try and follow is only open an email once. It's so easy. You're in clinic, email comes flying in. You think, well, I'll just have a quick look at that. You open it, you half read it, you shut it again, and you don't actually deal with it till later. Well, every time you open that email, you waste time. So how can you best manage your time? Sharing your stories. So it's really important if you have a bad day and if you have a good day, that you particularly if you have a bad day, that you don't go home and just chew on this and get upset. We've all had difficult days. We've all had difficult patients. We've all had difficult stories to share. Please, please make sure you share it with your colleagues and your seniors as well at work. Support and respect everybody in your team, hugely important. Some people find mindfulness and yoga very helpful. Headspace is a great app. This is a great TED talk you might want to watch about mindfulness. Getting out into nature, it's lovely if you can. Certainly has got some very positive potential effects on our mental and physical health. And then, so those are just some ideas to put in your toolbox. And I just want to finish with this idea of a lifestyle medicine challenge for doctors. So the really challenging thing is, how do we move from being this sort of doctor to maybe being this sort of doctor? And we need to do this both for our own health and for the health of our patients. And a patient is much more likely to listen to a doctor who looks like this when they're talking about a healthy diet than a doctor maybe who's looking like this. And there's a very clear relationship, there's good research on this, between the health of doctors and the health of their patients. And we know that physicians can positively influence their patients' health habits by counselling them about prevention and about good health promoting behaviours. And we know that physician counselling is strongly related to one's own health practices. So if you have a physician that smokes, it's much less likely that they're going to tell their patient to stop smoking. And if they do tell their patient to stop smoking, to do so in a way that's going to be successful. And over the years, I have come to be a bit cynical about sometimes what patients tell me. You can't believe everything people tell you. So this next picture, it's a true story. A patient was telling me that they were taking their dog for a walk every day, and I was really pleased. I was so pleased. They were going out and they were going for a walk, and then I saw them. This isn't a picture of them, and this is what they were actually doing. So just beware that they were taking their dog for a walk, but not in a way that they were getting any meaningful exercise for themselves. And there is certainly also, there's other research that's been done saying that physicians' disclosure, if we can disclose our healthy personal behaviours, it really improves credibility with our patients and can motivate patients. And a wonderful example of this is an organisation called Walk with a Doc, which started in America but is now, there are practices all over the world doing this, where on a regular basis doctors and patients are actually walking together, which is wonderful. And this is a great paper actually looking at physician disclosure of healthy personal behaviours and improving credibility and ability to motivate our patients, by Erica Frank from Canada. And one of the things they say in that paper as well, it's incredibly important that educational institutions need to encourage health professionals in training to practice and demonstrate healthy personal lifestyles. That's something that I'm doing at the moment, is teaching medical students about lifestyle medicine and about their own health and well-being right at the beginning of medical school, because I want them to have a toolbox that's ready for them to use during medical school and then in their work life all the way through. So my take-home message to you today is just the same as the message you get on an airline when they talk about, you know, you need to, if there's a problem and the oxygen masks come down, you put your own oxygen mask on first, and then you put on the oxygen mask of the person, you know, who's dependent sitting next to you. It's exactly the same. You cannot look after your patients if you don't look after yourself first. So that's it from me. I do hope you've enjoyed this module, and I hope you carry on enjoying the course. Thank you so much. Bye-bye now.